Hi, I'm Dr. Shruti Tannan. I am going to invite Dr. Becky Knackstedt, our guest tonight. So give me just a moment and then we'll get started. Oh, I'm so pumped you're here. So I want to tell the folks who are joining us right now who you are and why I'm so honored that you're joining us tonight, Dr. Knackstedt. So Dr. Becky Knackstedt is on faculty at Duke University. She's a plastic surgeon. She's also an MD PhD, which gives her a really unique perspective as someone who's both a clinician, a technically proficient and gifted surgeon, as well as a researcher. When we were at our plastic surgery meeting, our North Carolina Society of Plastic Surgeons not too long ago, after you gave your presentation, I mean, it was like pin drop silence. Like it was literally like mic drop. Everyone was just literally, what did you just say? And scrambling to the microphone. There were so many questions. I mean, I'm pretty sure the podium was like slammed afterwards. So you inspired me amongst many other colleagues, so I want to launch right into it. I was hoping you could tell us what prehabilitation is and how this kind of became something that's like your passion, what you've really focused a lot of energy and education into, if you don't mind.
Yeah, no, a pleasure.
Thanks.
So, um, my background has always been in nutrition. It's something that I've been really excited about. And when I started my practice, I really thought that if a patient had a good diet, if they had some good supplements, like that's all they needed. And then as I got to know my patients and really learn what was going on with their lives, there was many other things that I could see was impacting their outcomes. They're talking about not sleeping, they're anxious. I mainly deal with breast cancer patients, so they have their own anxiety, stressors, and pains and family situations. And so I dove into the literature to see what there was, and there is a ton of literature supporting the fact that all of those factors can either positively or negatively impact your surgical recovery, your outcomes, and just your overall experience. So then I started to investigate, well, what can we do in that pre-surgery period to help those factors?
Wait
Help.
1 second. I
Yeah.
think I realized I had one of my echo chambers going. Sorry. Continue.
Um, so then I started to think, what can we be doing then in the pre-surgery period to help women heal, have better outcomes, have better surgical experiences? And what I found is that this idea of prehab, which is just rehab before an event, so before surgery, is described in other surgical disciplines like colorectal surgery and cardiac surgery and orthopedic surgery, but it really just hasn't made its way into plastic surgery yet. And that's actually really interesting because when you think of plastic surgery patients, a lot of times those are elective surgeries. It's not like you're in a car accident and need to fix your femur fracture. You have time to optimize your sleep and your stress and your anxiety and your nutrition so that you have the best surgical experience possible. So I think it's really exciting that it's getting attention in plastic surgery, and it's definitely long overdue.
I appreciate it. I noticed that when you talked about prehabilitation, you kind of separated it into different quadrants. We only have about 45 minutes. So even though I have like all these, my list of questions is 2 pages, y'all. So I literally was like, let me just trim it down. I think I wanted to start with physical prehabilitation. I wanted to learn a little bit more because when you and I chatted briefly, and I wanted to share that with everyone here about a lot of plastic surgery, just I'd say the bulk of it is like breast and body, right? So what are so for those of our patients and plastic surgeons who are logging in right now, what are some granular things, like things they can take away that, okay, here is what, if I have an upcoming surgery or if I have a patient who has an upcoming abdominoplasty, breast surgery, reduction, lift with implants, what should I be teaching them to do in the 6 weeks leading up to surgery? Because like you said, it's elective. We have the luxury of knowing 3 months from now, 6 months from now, here's what we're planning. What should we teach these people?
Yeah, muscle is finally getting the attention it deserves. For so many years, it was just you build muscle because you look good and you feel good. But muscle is so important for healing. Muscle regulates your blood sugar. It's actually an endocrine organ. So it's sending signals to how your body is healthy and functioning. And so building muscle mass before surgery really serves two functions. One is it's going to create a reserve of protein because your muscle is made of protein for healing after surgery. That's the building blocks of healing. And then your surgeon's going to tell you, well, don't exercise for 4 weeks after surgery. So there's so many things kind of eating into that muscle or protein reserve.
Gotcha.
So the higher up you can start, the smaller that dip's going to be. So the faster to getting back to baseline. And so with that in mind, when I started practice, like we've talked about, I would just tell patients like, just increase your lean muscle mass. I don't care what you do, just
Right.
build muscle. But then I was getting feedback from patients that when they did strategic things before surgery, it actually made a difference functionally. So once again, for breast reconstruction, we often tell patients don't lift more than 10 pounds, don't push yourself out of a chair. So if your chest and arms are out, then you're relying on your core and your legs to get out of bed, get off the
Mhm.
toilet, get up the stairs. So yes, build lean muscle, but really focus on what you'll be relying on after surgery. So now I tell patients, think about what will be out after surgery and then bulk up the things that you'll be relying on.
That's smart. So when I think about that, we're talking squats, body weight, and if you can add weight, that would be great. Maybe some deadlifts. Of course, like crunches, but there's so much more. I think of squats as like surprise core. And then even I think improving lean muscle in your arms and chest because it's going to be wiped out is probably helpful. Is there anything else you can think of that I'm not thinking of right now that's not coming to mind?
No, I think that so many aspects of having surgery is overwhelming. So my whole goal always with prehab is just to keep it as simple as possible because we don't want to overwhelm patients more than they already are. So
Yes.
are there a gazillion really cool core exercises you can do that like look cool and sexy? Yes. But you can also just do things like sit-ups and planks and squats. Very, very simplistic. You don't need weights. You can use your body weight. You don't need a special gym membership. You can go to the park or the playground or just walk outside. But keep it simple because that's what's going to make it accessible and maintainable for patients.
I'm seeing some questions come through. A great one about protein intake and nutrition, especially given that that's your passion and you spent so many years studying that. Tell us a little bit about your insights. I remember a couple of things from the society meeting, but I want everyone here to get to share in your wealth of knowledge on this.
Yeah, I think that there's some things that are very obvious. So much of prehab is just taking care of your body, but going that extra mile. We know that eating healthy, exercise, sleep, we know that all those things are important for health and wellness, but it's just so critical in the before surgery period. So when you think about nutrition, the main things that I think of is protein intake. And protein intake for two reasons. Once again, it's going to help you build your lean muscle, but also it is what your body needs so much to heal after surgery. So if you're not intaking enough protein through your diet, your body still needs that protein. So then it just break down your muscles. So building up your lean muscle before surgery and then after surgery, providing your body the healing building blocks it needs. The other thing is that there are really well done studies showing that when you have surgery, your body goes into this state where it just starts crazy using up all of your macro and micronutrients. So things like vitamin C. Having just the recommended daily allowance of vitamin C, which is enough in your normal day to day to prevent scurvy, it's not enough to, which, we talk about no one gets
Yeah,
scurvy pirates.
right.
But, it's not enough to support what your body truly needs. And so when you look at studies, when you look at different micronutrients like vitamin C, zinc, magnesium, all the ones that we're thinking of, it's not enough to just get it through your diet. You
Mhm.
really do need to think about targeted strategic supplements that are just supporting your body through this healing process, not
Mhm.
necessarily term, but at least for a couple weeks before and after surgery.
That is so helpful. So to summarize, in terms of not just focusing on protein intake, so building up lean muscle, because that protein will serve us well, because you're going to be in such a catabolic state, or
Mhm.
it's just going to be problematic when you're in surgery and after. And so, and then not just the macronutrients, but getting those micronutrients. And so you mentioned zinc, vitamin C, magnesium. So for our plastic surgeons, because we have a fair number of plastic surgeons logged on who I know must be like curious about, hey, can you give us some like examples, recommendations, or perhaps some references on where we can get good, like here's a good list, or here's a good resource. What would you share?
Oh, I have so many thoughts on that.
Right.
So the first thought is that
In 5 minutes now.
how much time? So The first thought is that anyone who's ever had surgery has heard the spiel, stop all supplements before surgery. So it's important that we address why and why we need to rethink that. So supplements are not well regulated. They're not regulated by the FDA. So when you buy a supplement, you're not sure you're getting what you think you're getting unless you buy a quality third party validated supplement. So that's the first reason why you got to be a little bit skeptical of supplements.
Of course.
The second is we know that some supplements are dangerous to take around the time of surgery. High dose vitamin E, ginkgo, St. John's wort, those
Yeah.
increase the bleeding. So now we have definitely unsafe ones,
Mhm.
and instead of going through someone's supplement list that, as you know, can sometimes be, 30 things long, it's just easier to say, stop all
Stop
supplements.
them. I know.
The challenge is, though, is that there are evidence-based supplements that have been shown in randomized control trials to be not only safe leading up to surgery and after surgery, but also very effective. So if you tell someone to not take supplements for 2 weeks before, 2 weeks after, or longer, you're missing that critical healing window.
Hmm.
I do recommend supplements to my patients. Where can they find it? I have the list on my Instagram page. It's like literally every other reel. I have like comment supplements, and I'll send you
Yeah.
my um.
Perfect. Good deal.
But
I love it. We can send folks there. I think that would be good.
absolutely, and
I appreciate that. Oh, go ahead.
if you
Sorry.
can find it, please let me know. But I always tell patients because I get so many DMs saying that my surgeon told me to stop everything. And so I don't want to step on toes. So I always want to respect the doctor-patient relationship. But I always encourage patients to ask why. And I love when my patients ask me why. So when I tell them to wear a binder or compression and they ask why, I love that. And it should be the same conversation where if your doctor tells you to stop your multivitamin or your vaginal asking why is a very good question, and seeing what their answers are. Because a lot
Oh,
of times
yeah.
it's just things that we were told, that it's dogma. Our predecessors told us, so we just do it,
I did.
even though the data continually changes, and we need to stay up to date with the emerging evidence and research and really supporting our patients holistically.
I appreciate you bringing that up because another dogmatic thing we were taught was that estrogen is bad, right? And we just saw that black box warning come off, and I'm sure it's like blowing up your, all your discussion forums. So tell me a little bit about how estrogen factors into the prehab plan. We've already changed all of our protocols here to allow to continue the patch. I mean, everything is showing that we need that for our patients in this critical
Yeah,
time. I mean, these menopausal, perimenopausal women at risk for osteoporosis, fractures. I mean, there are so many things that are changing.
yeah.
So tell me how that factors into prehab.
Yeah, so what you alluded to, if you're not familiar, is the black box warning off of hormone replacement therapy, any type, vaginal, topical, oral, was just lifted. And that was based on old data from the Women's Health Study showing that it increased different cancer risk. And so, with that being lifted, there's going to be this whole new group of women that are thankfully benefiting from this really beneficial medication. Once again, oral, topical, vaginal. So, why did we tell patients for years to stop it before surgery? Estrogen, which is one of the components of hormone replacement therapy, is pro blood clotting. That's super scary, right? We don't want people to have blood clots before and
Right,
after.
right.
The challenge is that most of that data was based on either doses of estrogen that are no longer used or formulations that are no longer used. But with that, there really is not a lot of updated evidence because it was just carpeted. No one took
Mm,
it. But
right.
now there's some emerging evidence in the trans female literature because they're on estrogen. And so
Mm,
telling these patients to come off of their oral estrogen for 4 weeks before and 4 weeks after is very mentally challenging for these
yeah.
women. And so there's data coming out in that literature showing that even oral estrogen is safe and not pro-thrombotic or pro-blood clotting. That's still a little dicey. I think that
Okay.
especially for longer surgeries or surgeries that might have an increased risk of blood clots, questionable.
Okay.
But importantly, transdermal estrogen does not increase your risk of blood clots. That's been shown extensively in the literature. Vaginal estrogen does not increase your risk of blood clots, and neither does IUDs. And the reason
Yep.
for that is either it's low dose, like significantly lower,
Mhm.
or it bypasses the liver, which is where the oral estrogen goes, and
Mm.
that's where pro-clotting comes from. So, substantial literature to show that it is completely safe even if you're having surgery. I would say the only patient population that I would be a little bit wary in is if they're pro-thrombotic or pro-blood clotting for like a genetic condition like factor V or something where you know
Right.
that they're already at a
Hmm.
risk.
Certainly.
But I mean, it's wild to me. I had a patient reach out to me on Instagram who said her surgeon, before they would do a breast procedure, he made her confirm that her Mirena IUD was removed. I mean, anyone who's had an
IUD.
IUD,
Wow.
no,
Oh.
no, no,
Mm.
that ain't a walk.
I guess that was a guy. Wow.
That's
Ugh.
right. Um,
That's
so
wild.
the only patient population for me that I routinely take off of estrogen modulating medication is for breast reflaps. If they are on an estrogen modulating medication, we do have data showing that that can increase your risk of blood clots. But apart
Yes.
from that, birth control pills, transdermal, vaginal, there's no reason to come off of it before surgery.
I so appreciate that. I appreciate you sharing that with me. And I hope for a lot of the plastic surgeons who are following that this is something that you get curious about, feel free to reach out to me. I'm happy to share the research that Dr. Knackstedt shared with me, some of these papers she referenced. And for the patients, you are your best advocate. You know, our healthcare system is changing every day. I look around and I'm looking at the age and experience of many folks around us. So ask questions because you're catching people either at the very beginning of their training or at the very end, and they've been doing it that way for 30 years. So be curious. And if you don't get real answers, keep pushing, you know?
Mhm.
So I wanted to talk to you about GLPs. I'm noticing a lot of my patients are increasingly on it. And of course, as you know, we're prescribing it in our office because I don't want my patients trying to starve themselves
Right.
just so that they can hit a weight target. You know, like let's do it in a measured fashion. Let's make sure that, like we've talked about, you're getting your macro and micronutrients. How can we balance being on a GLP, potentially being in perimenopause, and prehab? Like, what, please,
Yeah.
what's the magic formula?
It's hard. It's going to become so prevalent, especially with these like mail order systems now where you can just sign up and just get GLP-1, especially microdosing, just sent to your door with no counseling, no, like medical oversight. And so when I think about GLP-1s, I think of really three things. So the first thing is what we are mainly thinking of surgeons in relates to gastric emptying. So GLP-1s slow down the release of the stomach contents, so food stays around longer, which increases your risk of aspiration when you're intubated. And so the anesthesia recommendations are always changing. About, at least at Duke, our patients, if they're on that medication, have to be on a liquid diet the day before surgery. So that's
Okay.
well. There was just a consensus statement that was released saying that you should not be on an elective surgery. You should not have an elective surgery if you're within 4 weeks of a dose change of a GLP-1. This came out this week. And their rationale for that was people tend to have this gastric emptying issues mainly when they're starting or with dose escalation. So that's new.
Interesting.
So now
That
they're
is new.
cancel surgeries. Like that's a significant change.
Yeah.
And then I think of the fact of what GLP-1s do that make them so effective. They make you basically anorexic. They're introducing medical,
Mhm. That's exactly what they're doing. Yes.
which is great for weight loss. And what I found is when we do breast reconstruction, we have a BMI cutoff of 35. And
Mhm.
so GLP-1s, any patient who was above 35, you have to lose weight. And I would say the return rate was almost zero because patients just could not lose the weight.
Yeah.
Ones, it's very, very high that patients are coming back 3, 6 months later having lost 30 or more pounds.
And
The
a lot of that is lean muscle, which is really
challenge,
frustrating.
it is. Measure their albumin, which is a marker of their protein stores, it's like gastric bypass levels.
I
It's
know.
it's through the floor. And the challenge with that is like we talked about is what do you need to heal? You need protein. And these patients, if they're on those GLP-1s, have a really hard time building that protein back up. So what can you do if you're on a GLP-1? The first is talk to your surgeon about your albumin levels or your doctor if you're pre-surgery consultation. Your albumin should be measured every 3 to 6 months, looking at those changes. The second is you got to prioritize protein. You got to be having somewhere between 100 to 150 grams of protein a day, which is a lot of protein.
But
And if you've ever tracked your protein before, it's hard to get there when you're not on a GLP-1. So it's really hard to get there when you're starving.
and
And
for vegetarians and vegans, it's incredibly challenging. You have got to be vigilant.
right, because really, if you're eating a lot of incomplete protein sources like beans, lentils, you need to even be higher to get your complete protein goals. So measure your protein, prioritize protein, and then you got to be doing resistance training. You got to be lifting heavy things, and you should be taking creatine too, because that's going to help you make your resistance training more effective. But
Mhm.
most people aren't being told this, and then they come to the plastic surgeon's office, and then they get mad when their albumin's 3, and we say
I
3.
can't do surgery like that. Yeah.
Right. But we're not gatekeeping surgery. We just, as you know,
Mm-mm.
want to do
Mhm.
what's best for the patients. And if you're spending a lot of money on a cosmetic surgery, you don't want to have open wounds and infections.
Yes.
Your body was not ripe for healing.
Right. So in terms of timing, because something my patients are always asking me, and I'm sure some of the folks, some of the names that I'm seeing on here are probably like, when is she going to let me start it back? Right. I have tended to, so I've done what you have been suggesting. I try and ask patients to get their pre-albumin measured as well, just because sometimes that albumin can change if they happen to
Mhm.
have a cold recently. The frustrating thing is it half the time the doctors don't get it. But my question really is, when you're thinking about restarting it, the goals that I have used is I like to see my patient at a steady state from a healing standpoint. Like, are you at a good, we've hit 6 weeks, surgical sites, all of the absorbable suture is dissolved. Now it's your body's stable scar. And I feel like we've kind of gotten over that main hump of that early potential for wound breakdown.
Mhm.
And so that has been my kind of like, especially for some of the larger procedures, we're talking breast reduction, abdominoplasty, or mommy makeover, where we're combining stuff. What are your thoughts about restarting these GLPs?
I think there's two things to think about. So the first one is what you said is wound healing. So I think waiting 6 months, 6 weeks or longer, your absorbable sutures are being degraded, the incisions are healed, they're back to activity restrictions. But then you're also about the long-term aesthetics. And so for breast reconstruction, I do a lot of fat grafting to
Oh, yes.
pores. If you're doing facial plastic surgery, you're probably doing fat grafting as part of your
Right.
facial, and so it's telling patients that your body is going to melt the fat. So whether it was fat grafting or a
Mm-hmm.
BBL, fat grafting, or
That's a
if
good point.
they like the size of their breasts,
Mm-hmm.
going to change. And so some of my partners who are cosmetic surgeons, they actually tell patients they shouldn't have aesthetic surgery until they're done with GLP-1, which
Wow.
for some patients is never. So that's a
Right.
challenging
Yeah.
conversation to have. But if you plan on being on it for the long term, you just have to think about the long term aesthetics of what you just spent a lot of money on.
I think that's important. I think finding that balance, because some people need it. They need it to quiet the food noise. And others I've found, especially my perimenopausal patients, sometimes it kind of kickstarts things. But then I find, and then they'll eventually come off of it maybe after a couple months, once they're able to shed that, 10 pounds, that bloat, that inflammation. But then the holidays come around, or they go on a cruise and they sort of fall off the wagon, and then we have to get them back on. So it's a little bit of ping ponging, but I think I have never looked at it that way, of saying, hey, maybe you should just wait until you're done. I think you've planted a seed there. There are so many questions,
I
and
know
it
it's
is incredibly distracting. I'm like, I'm trying to listen to what you're saying, and all this is happening. I'm clearly 43 and not 25. So let me look through. If you can give me a second to see here, because we have some good, okay. Here is a good question. So is there any data regarding creatine supplementation to prevent or mitigate lean muscle mass loss from GLP-1s? You were just
not.
talking about that as a recommendation.
Yeah, I don't think there's actually been any well-done studies specifically in GLP-1, but their creatine is the most studied supplement ever. So
Yes.
I think that when I recommend it to my patients, I recommend 2 doses depending on what their goals are. So if their goals are just to increase lean muscle mass, it's 5 grams a day. If their goals are to get all of the cognitive benefits that are now coming out, I recommend
Mhm.
10 grams per day, and especially lots.
That's a lot.
It's expensive and it you gotta
It's not fun. It's not fun. How about, or what about the taurine? What are your thoughts on taking it with taurine or not?
Yeah, I see this advertised all the time on social media.
I
There's
do
those
too. Yeah.
that are promoting it. I don't know the science of taurine a lot, but so for health and wellness, I don't know the data. For surgical recovery, there just isn't. It's
Yeah.
had studied. But if the price is the same, I mean, creatine monohydrate is the OG. Go with that one. You don't need the
Right.
HCl, you don't need the microionized, but it's still expensive. It can be a little bit rough on the stomach. So if you do use the 10 grams, you got to split it into at least two
Right.
doses.
Absolutely. Oh my God. 10 grams. That's like the worst news ever. Give me some good news. Come on. All right. Let's see here. Oh boy. I'm definitely not doing this right. It's like, do you want to remove this person? No, I'm just trying to read the questions. Um, oh yeah. So if some of our folks wanted to find some of your prehab information, what would you suggest for them as we start to wrap up? Like if they're like, hey, I want to learn more, obviously they can follow you, but give us some more places that they can go through either. Anyway, yeah, what are some resources you have?
There aren't good ones. And
Mm,
that's really what prompted me to do what I'm doing because I would talk to my patients about this,
yeah,
but then they would say like, look, is there just like a singular resource that I can look for this? Because I
right.
can't get all this in. And there is not.
Mhm.
So I have a lot of resources on my Instagram page. I have like different links for like sleep aids and anxiety and questions to ask your breast surgeon and plastic surgeon. I'm writing a book. So that should be, I'm looking for a publisher.
Oh, I'm
And
excited. That's
yeah,
awesome.
but there's not the challenges, as an MD, you can appreciate this, but a lot of the things in prehab are a little bit soft and fluffy, like sleep and anxiety. And
Mindfulness and yeah,
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 and it's not something a lot of surgeons like to get behind, because to be frank, it's hard to do a placebo randomized control trial on music therapy. So, you know,
right.
low risk potential benefit, but surgeons, it's hard to get behind some of that soft and fluffy stuff. And so the people who have really adopted these techniques tend to be the more alternative medicine practitioners, which
Mm-hmm.
I'm certified in functional medicine, so I feel comfortable
Yeah.
saying they don't have a great foundation of knowledge.
Mhm.
So they take a lot of things out of context. They're not doing evidence-based protocols. So
Wow.
it's hard to find an evidence-based platform that discusses things in the light that they deserve. So even things like red light therapy and vibration boards, where there is some science supporting it, they get blown out of context by influencers and by people
Yeah.
making money buying their
Right.
affiliate. So long-winded answer to there's not great resources.
No, I appreciate it. Any parting thoughts? I have picked your brain. I appreciate you being so flexible. We're talking 1 minute about nutrition, another about GLP, and I mean, we're just like all over the place. So thank you for flexing here and pivoting. Perhaps there are things we haven't discussed that you're like, oh no, I was really hoping I could share this with the larger audience. Tell me.
I think what you said before, you have to be your own advocate as a patient. And so some of the messages that I've gotten from patient, not my own patients, but other patients on Instagram would be like, I tried to bring this up with my surgeon and they like shot it down, would not engage, didn't recommend anything. It's like, how do you recommend I proceed? I don't want to solely the doctor-patient relationship. So I
Right.
think one is you got to find a surgeon with whom you're comfortable. Two, you can have those hard conversations with. My patients ask me hard conversations or have hard conversations with them, and it doesn't make me think less of them. I actually love that. I love engaged patients. So if you're a patient, you should feel empowered to ask your surgeon questions and to advocate for yourself. And I think asking open-ended questions. So what I recommend to patients is asking, how can I prepare for this surgery? And if they don't have an answer, then say, what are the biggest complications or risks with this surgery? And what can I do to decrease those risks? That's a more targeted question that some surgeons might be able to better answer.
Mhm.
Answer that, then ask, whom can I talk to help get
Yeah, who do you have that communicates with people here? I
someone?
I
It
think you're right.
pisses them off.
Communication is so
No,
key.
yeah, it's not going to make your surgeon mad. And if those questions, those open-ended, vague questions, make your surgeon mad, you need to find a new surgeon.
Okay.
But
Yes.
talking to a dietitian, a counselor, a sleep therapist. So that's the first thing. Advocate for yourself. The second thing is that this is meant to feel empowering. This is not made to overwhelm patients.
Yes.
And Patients, there's been studies asking patients, do you wish you had more information? And the answer is overwhelmingly yes. So first off, once again, if you're a patient, ask those questions. But there's also studies showing that while I would love every patient that I operate on to have a good diet and supplement and sleep well and have a meditation practice and have a mindfulness practice,
I want that too. Can you
we
sign me up for that life?
and our complications would be zero.
Hmm.
It's you can't expect patients to do that, and as a patient, you can't expect yourself to do that. But the good news is that there are studies showing that even if you adopt just one thing, just focus on your nutrition, just focus on your sleep, just doing one thing still is evidence-based to decrease complications, improve your recovery. So I like patients to journal. I'm a huge fan of journaling and write down what are the things going on in my life that I think I really need help with, whether it's sleep, anxiety, nutrition, and then what are the things I'm willing to work on? And then how do I get that help? And if you can just figure out one thing, it's still going to improve your surgical experience. And just don't get overwhelmed. Don't get lost in the forest. Just focus on one thing and feel empowered to talk to your surgeon about these things.
I love that so much. I'm going to wrap it up. Thank you. I sincerely appreciate you sharing your weeknight away from your family, giving us this like snippet of your breath of wisdom. This is definitely going to be part one of many. And I look forward to connecting you to some other colleagues. I think if you haven't met Dr. Jocelyn Whitstein, we need to do another live with her because she is just as passionate as you are and just as knowledgeable. So I'm really excited to connect and continue this conversation. Thank you so much, Dr. Knackstedt.
Thanks for having me. Have
You too. Bye.